Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name's Marc Ryan. It's a pleasure to be hosting this podcast, and I thank everyone who's listening in. As I always do, I sort of start out with a brief overview of the Healthcare Labyrinth website at healthcarelabyrinth.com. And we sort of do four things on that website. Number one, we have a weekday daily news feed, and on that news feed, each night I publish it. And I sort of have perused about 24 websites throughout the day. And I basically give you links to important articles of the day, as well as some summarization and sometimes some commentary as well. So it sort of is a shortcut to get to the biggest news articles of the day by going to the news tab on healthcarelabyrinth.com. We also publish 2 blogs a week at the blog tab, and these are on the big issues of the day. And lastly, once a week, we have a podcast at the podcast tab where I go through a big issue of the day as well. You're listening to it now. You may be listening on the website, or you may be listening to it at leading internet sites or applications for podcasts. So that's sort of the main 3 things we do on the Healthcare Labyrinth website or healthcarelabyrinth.com. Lastly, you can also purchase my book at the website. It is also called The Healthcare Labyrinth. It is a guide to navigating health plans and fixing American health insurance. It's available at all leading retailers. You can get some more information at the website. It is available in print form, ebook form, as well as audiobook form. So with that done, we are going to jump now into the purpose of and topic of this week's podcast, and it is all about price transparency. What price transparency is in healthcare, why it's important, and some of the actions being taken by regulators to really promote price transparency out there. So first off, let's begin with that all-important, why do I think price transparency in healthcare is important? Now, let's say first and foremost that healthcare is perhaps the most opaque buying experience out there, right? Providers, payers, others in the healthcare system go out of their way to make sure that all of us have absolutely no idea what the price of a given service is. It's absolutely amazing that that's where we find ourselves, but in many ways, it's the absolute truth. Some people may accuse me a bit of hyperbole here, but I think if you really think about it, that very much is the case. If anybody could go out there and really tell us with precision what that, let's say, bill charge of an inpatient stay is going to be, what the allowed amount that a provider is going to pay, as well as what is ultimately the price a patient or a member of a health plan is going to pay in terms of cost sharing. I don't think there's anybody, and I count myself among this group, that can really with precision tell you really all of that information. It's just a sad fact of life in the United States. In most of the developed world, whether we're talking about socialized medicine or single payer, or even most of the developed world that has private affordable access, we're dealing with publicly available prices for healthcare services. And if there are cost-sharing requirements by a patient, it's pretty well known, pretty well published. And the truth is, many folks in at least the socialized medicine sector or the single-payer sector are not really worried too much about the size of cost-sharing anyway. But here in the United States, it is this tremendously opaque system. And it really is driven a bit by how we've set up the pricing system. I'm not going to go too deep into this area, but the reality is that on the medical side, we'll cover the drug side in a minute. On the medical side, We have a system, again, as I reference, build charges, which are what a provider may want to charge. You can maybe call it a list price, for example. And then you have these allowed amounts or allowed charges that reflect the discount that a provider has agreed to pay to an insurance company or some other entity. And that is the amount that actually will be paid. And then lastly, you have your cost sharing amount. In the retail drug world, it's actually something sort of similar. Generic drugs are sort of easier to understand, but they are also potentially have different prices based on something that's called a maximum allowable cost list that is established. But again, it's much easier to sort of understand what generic drugs are going to cost you. But in the brand world, we have a system where we have egregiously high brand list prices, so to speak. And then we negotiate with PBMs and plans a rebate, which will reduce that gross or list price down to a sort of a end price in the market. The sad fact is, when that rebate actually comes and gets reimbursed from the brand manufacturer to the PBM or the health plan, it's way down the road, well after a drug has been picked up at a pharmacy at the so-called point of service. So consumers don't get advantage of the net price. They're pretty much paying their cost sharing based on the list price. And so the difference between the list price, again, and the rebate gives you sort of a net price, and your cost sharing in the drug world is largely based on the cost of that gross price, which means great unaffordability, not only from a high list price basis, but from very heavy cost sharing that often occurs within the drug world as well. So again, opaque is the word for it. The American healthcare system, in terms of how we price and what we make public in terms of price, is just incredibly opaque. So back to the issue, why do I think price transparency is important? Well, if we think about what we do every day in the rest of our life, we do have knowledge of price, and we are making decisions based on price. And I think someday we could get there in healthcare as well. And that would have an absolutely positive impact on costs and potentially quality in our healthcare system. So let's just start off, for example, with every day what we do on price and how it might potentially be adopted in the healthcare world too over time. So number one, we're in a digital age today. When I grew up, by and large, we were in brick and mortar stores, but we even practiced some price consciousness or value consciousness, as I call it. The two things that I think really lead to consumption in our world. Price being the lowest price, value consumption being paying for something based on a perceived value. The price reflected in what you think of the quality or the value of that commodity or service. So price and value really sort of go into our consumption out there and our decisions about what we're buying. But a good example might be on the sheer price side is going to a website or going to a store, or back in my day, going to multiple stores because there was no digital age, and you're sitting there comparing prices. It could be something in a grocery store, it could be something in a clothing store, or it could be, in this day and age, something that's sold on various websites and perhaps still a brick and mortar store like Walmart or, say, Target or some other mall out there. And so you're basically going out there for a given commodity saying, I just want the lowest price. There's not any perceived difference in value with this commodity. I just want to get the best deal possible, and you're going out and buying that. On the value side, I think an example there might be furnishing your home. Sometimes budgets are tight and you may go for pretty much that lowest piece of furniture when you're, trading out your family room furniture or buying a new bedroom set. But at other points in life, you may actually make a value purchase. You might pay more based on the perceived value of that bedroom set or that family room furniture and go that way. And today, again, even for furniture, we're buying in brick and mortar stores. We're comparing value and costs, and we are also buying on the web, and we're getting furniture shipped to our houses and things like that. So again, purchasing based on cost or based on value is occurring in our everyday life. And I would argue, going back to the topic of healthcare, that would absolutely be a good thing if we were taking and understanding price as well as value in our decision making for consuming healthcare. Today, by and large, because of the opaqueness of the healthcare system and the lack of understanding of price, we pretty much take for granted what a practitioner may tell us. But that practitioner or that provider may or may not have our best interest involved. A good example, which I always talk about, is the fact that today the majority of providers out there are actually employed by a hospital. No offense to hospitals, but a doctor employed by a hospital will likely want to perform a surgery or some other procedure at a more expensive outpatient hospital setting or something like that. You, in fact, could get that much cheaper, perhaps in a physician setting or an ambulatory surgery setting. And so in that way, while you may trust your provider, he may or may not be giving you the best advice about where to procure that service. And we know the way benefits are designed with cost sharing, your cost sharing could be much greater if you obtain a service in an outpatient hospital setting versus an ambulatory surgery setting or perhaps a physician office. So let's go a little deeper on why it's important to consider cost and value as an example. So I talked a little bit about bill charges at the top, the allowed amounts by a healthcare plan, and then your cost sharing, which depending on your type of plan could be based on bill charges in terms of a drug, but may also be based on allowed amounts. But I want to go a little deeper on this one because the way in the medical service world, not talking about retail drugs, the way that cost sharing is really set up is pretty much often based on the place of service. And a general rule is that the more expensive the place of service, the more expensive your cost sharing is going to be. And I made reference earlier to physicians being owned by hospitals, and the hospitals preferring that procedures be done within hospital-based settings and things like that. Let me give you a real-life example of how this works. And they actually come from my own family life here. And the first thing I want to talk about is where cost sharing may be different between two places of service. And my wife, many years ago, went in to the doctor and needed to have a procedure done. And the doctor basically said to her, there are really two choices here. On this day, which is much more convenient for me, I do this kind of procedure at an outpatient hospital facility. It's connected to this office, and I can get you in to get this procedure much more quickly if you do it at outpatient hospital. He did, with much reluctance, give her the ability to have the procedure performed at an ambulatory surgery center, but the days that he was there were less frequent at the time, and that procedure might have been several weeks out. And in essence, he sort of cajoled my wife to have that procedure at outpatient hospital. While I was pretty healthcare literate at the time, it didn't dawn on me the difference in price that this was going to cost me. So at the time, my health plan basically charged a $300 flat copay for anything done at an ambulatory surgery center. And that was for not only the physician costs, but also the facility fee. But when it came to outpatient hospital, I had a deductible plus 20% cost sharing of both the physician fee as well as the facility fee. While there was a negotiated allowed amount by the health plan that applied compared to the bill charge of the hospital, the reality is my final bill for my wife's procedure being done at outpatient hospital, place of service 22, versus an ambulatory surgery center, place of service 24, was the difference between $300 and actually what amounted to several $1,000s, because I had to pay a piece of it from my deductible, and then I had to pay 20% of both the physician and the facility bill. So that's a good example where price transparency might actually, if it was out there, might have better told me what the price in the outpatient hospital is going to be versus the ambulatory surgery center. But let me give you one other example, which is even more interesting to me. My wife, again, was having a minor procedure done at, in this case, an ambulatory surgery center. And it required, a reasonable amount of complexity to do this scan that was occurring. Well, my wife chose to go to a very prominent outpatient facility associated with a very large hospital system. Again, a place of service 24. It was an ambulatory setting versus another type of setting just probably several miles up the street from this same exact facility. When I received the bill, I was shocked to find out that the price of that procedure was going to be about $900 based on my benefit at the time. I looked up what that procedure was going to cost at the other facility because I was pretty familiar with prices for these procedures, and it would have been between $300 and $400 for that procedure at this other facility. And both of them were place of service 24. So what it shows you is that there can even be dramatic price differences within a given place of service, depending on what a plan can negotiate with a given provider in that area. And so again, these 2 points sort of show you that higher cost places of services will probably cost you much more based on your healthcare benefits than a lower cost. But even within, say, an ambulatory surgery center or potentially even within an outpatient setting, prices could vary dramatically between providers. And so my admonition to everybody out there is certainly plan for these elective procedures. You can't really do that for emergent situations, but certainly plan when you're doing elective procedures, even within place of service, to determine based on your benefit what might be the best approach for you to take. And one of the reasons that this is very important is because we've seen a fairly massive erosion of the amount of money that health plans cover in a in a policy versus the amount of cost sharing and expense that patients have to take on for this. And that's why it's so important to really hunt around for the best place of service, and even within a given place of service, what might be the most efficient, cost effective place to obtain that procedure. I don't think there was any value judgment in these two situations. The same doctor in the case of the outpatient hospital versus the ASC for my wife would have been performing the procedure, and certainly it would have been safe not only in outpatient hospital but in an ambulatory surgery center. In the case of the other place of service, there's no doubt in my mind that there wasn't really a value judgment there either. It was all about cost, and it was a difference of that $300 to $400 versus the $900. So please always check your places of service, and even within your places of services, please check the provider and perhaps hunt around a bit to see what your cost sharing ultimately is going to be, which oftentimes is based on that allowed amount. So anyway, just a quick understanding of why price transparency is so important. It materially impacts what you're going to pay for sure. Let's maybe talk a little bit about the furniture analogy. Would there be times where you might want to find a much better physician or a much better facility than another? Absolutely, there's no question about it. Recently, my daughter had brain surgery, and while her health policy was one that probably didn't have much difference in cost between various facilities out there, there was some slight difference. And however, when you're having major surgery, you may want to find the best physician in the best facility, and you can take into consideration both the cost differences that could occur between the negotiated prices with health plans and the provider at various facilities, even with various physicians. And that's why price transparency would even help there, even when you are making a value judgment by picking a more experienced facility or a more experienced physician. Let's talk next a little bit about what is happening in the world of price transparency. Well, I have to tell you that movement is very slow and things are very incremental. And it's going to take us a long time, I would argue well into the next decade, for price transparency to really take hold in the healthcare world and for it to be meaningful enough for people to sort of understand all of it. It's not to say that you won't start to see some things change over the next several years, but I think the real meaningfulness of it and the ease of use and things like that will probably take, I would say, roughly another decade is my guess. But nonetheless, I'm a huge champion of price transparency. Let's first note that price transparency requirements actually, and I give him a great deal of credit, came in under Donald Trump's presidency and his Centers for Medicare and Medicaid Services and Department of Health and Human Services. So the Trump healthcare folks really began the process of putting price transparency at work. And number two, the Biden administration, to their credit as well, has sought to implement the rules that were passed under the Trump administration and actually strengthen them along the way. As we know, initially, sometimes when rules are set up, they are not exactly what they need to be. There are ways to get around certain rules, and you need to sort of close off these pathways to get around rules, and that happens all the time. And the Biden administration is busy trying to strengthen rules to make sure that price transparency takes hold as well. So President Trump, President Biden, both very supportive of price transparency, and I certainly applaud both administrations. So let's talk about what price transparency measures are actually in place right now. So the requirements really touch upon both health plans and hospitals. So both health plans effective July 1, 2022, and hospitals effective January 1, 2021, have been required to post various pricing information on their websites. CMS is really prioritizing the use of websites here. We know that not everybody is very proficient in the technology, but it provides the best way to really make pricing available. So let's start out with hospitals first. They must report all their gross and net charges in a machine-readable format, as well as at least 300 shoppable services. And that would be for cash and payer prices in a consumer-friendly format. So again, this has been out there for hospitals since January 1, 2021. Compliance has been, a little bit sporadic, and we'll go a little more into some of the other changes that are occurring here, as well as some of the penalties that are being leveled. But again, in summary, hospitals have to report their gross charges, which I equate to billed charges, and the net charges, which would be what a payer would pay, in addition to the 300 shoppable services, which would be what you would pay if you came into the door with cash, and as well as what the net charges of their payer charges might be. Next, we have health plans. So again, since July 1, 2022, health plans have to report the allowed amounts and the contracted rates for hospitals and other provider services for all in-network covered services, and the billed charges that they receive and the allowed amounts for out-of-network providers. So basically what is trying to be done here is to have health plans post what are generally the allowed amounts sort of across the board, what they allow for payment, whether it's in network or out of network, and then to really disclose the contracted rates that plans have with hospitals and other providers. And in addition, health plans are required to have personalized pricing and cost sharing estimators for about 500 of the most frequently used services. So up in the hospital section, we talked about 300 shoppable services. In the bottom part, we talked about 500 frequent services for health plans where you have to have the price and cost sharing estimates. This is really an effort to go beyond just posting gross and net prices, so to speak, for hospitals and health plans, but to actually make it pertain to the member experience, to sort of show what members might actually pay. Now, here's part of the problem here. The initial rules were only as good as trying to bring price transparency to the fore, right? The rules were not altogether clear. How hospitals and health plans interpreted them was not always clear. And frankly, there was a bit of gaming. Some hospitals and health plans didn't want to post at all. Other hospitals and health plans did it in such a way that reading the numbers was not really that easy. So the Biden administration has really gone down the road of seeking to clarify a number of areas. Number one, they're making it clearer about what they mean by machine readable formats. They're increasing penalties for noncompliance. And in general, they're just trying to take some of the ambiguity out of the rules so that they can enforce the rule, have hospitals and health plans perform well, and then obviously penalize if they're not doing that. In general, it's still very, very difficult for a consumer to really understand both of these hospital and health plan costs. There's just so much variation and issues that go into that, and I'm going to talk about that in a couple of minutes. But it is starting to bear fruit a little bit related to what researchers and what technologists are doing to try and mine the files and things like that. While that is still difficult for the researchers and the technologists, they are being able to mine some of the information, and they can sort of show us a little bit about the vagaries and problems related to the files that have been posted, and the complexity and the unknowns of pricing in our healthcare system in general. But clearly, much more work needs to be done, and I'm going to get into that in a little bit as well. So some may ask, why the big concentration on hospitals? We know that the health plan data has to show all sorts of services, including hospitals, but why mandate that hospitals provide data? Well, the fact is that about 1/3 in round numbers, let's say 30% to 1/3 of all healthcare expenditures across the board in the nation are spent in hospitals. That could be inpatient or outpatient services. So since that cost is about 1/3 of overall healthcare costs, that's why the focused a bit on hospitals. Hospital costs may be higher in the Medicare world, for example, and lower in other lines of business like commercial, but that 1/3 rule, 30% or so, is about right for inpatient and hospital spending. So let's talk a little bit about what we've learned so far from both the hospital and the health plan files that have been required since 21 or 22, depending on the hospital or the health plans. So generally speaking, what we found, and I combed the universe of various analyses to get this together, we found the following. Number one, compliance among hospitals has been somewhat low compared to health plans, but the Biden administration is increasing penalties in hospitals to attempt to get much greater compliance with posting of those files. Nonetheless, there are huge stores of data that have been posted by health plans and hospitals. This includes, again, both gross and net prices paid by plans to hospitals, and of course, what hospitals receive from plans, depending on the file. By and large, because of how the data are reported and uploaded, as I've pointed out, the average consumer cannot really use that data, even with the shoppable services and things like that. While health plans have a standardized schema, in some ways hospitals really didn't. And I noted that the Biden administration is seeking to clarify that through some refined hospital regulations to make compliance a lot better. There is also some evidence that data are not always accurate, and even that hospital and plan posted data conflict. Surprise, surprise. In some cases, the loaded files do not always tie all the data together correctly, and fields are certainly not intuitive. CMS does not really perform any quality control audits on either the health plan or hospital files. The agency is really seeking to penalize when there's non-compliancy related to the posting of the files, not the accuracy of those files. Hopefully, over time, CMS will get to that level of scrutiny to ensure that data are accurate. The rules also do not really require the posting of everything right now. I sort of outlined some of what's posted. So if you could decipher the cost, and could is a big assumption, it may not actually be complete. For the health plan portion, as an example, data are much more available for in-network activities rather than out-of-network, as a good example. And I've noted that as much as academics and researchers and technologists are trying very hard to really understand the data, they are clearly having trouble. There are so many different types of reimbursement and calculations that need to be made in paying a claim, as an example. that it's really hard to really come up with correct assumptions, and therefore academics and researchers are trying to make the best assumptions possible, but pointing out where there could be vagaries or inaccuracy. A good example in the hospital world is there are DRG reimbursements, which are sort of case rates. There are per diems, per day charges, and there are some other reimbursement types, and sometimes there are even combinations of the aforementioned. So that's one complicating factor. Dollars as well as percentages sometimes are necessary to calculate fees and appear in the file with very limited information. Sometimes you also need things like CPT codes, modifiers, diagnoses, and risk and severity to make these hospital calculations. And more importantly, hospitals can have hundreds of line items for a given stay, not all of which are likely accounted for correctly in these files. In the hospital data too, sometimes it's hard to tell what rate applies to what market and to what health plan. It's also very hard to know whether something is inpatient or outpatient, and whether a charge sometimes is for a facility or for a professional. And also it can be hard to tell what reimbursement type is applicable sometimes. So again, good examples of the trouble in the files in terms of what academics and researchers are seeing. I would also note that even if you could read one hospital's given rates, there's no easy way to compare those rates to another hospital's, at least not yet. And that's where the researchers and technologists and academics may be able to help over time. And certainly the same can be said for services in the health plan data. And consumers generally are hobbled by the fact that they would need to thoroughly understand their cost-sharing requirements to really understand the true impact of this data on them. So that's an additional concern there. I would note that, again, we're spending a lot of time on healthcare encounters involving hospitals, but they do only represent about 12% of all encounters. A bigger cost, of course, but only 12% of all encounters, and about half of those are emergency visits that likely cannot be researched. So there's a lot of issues bringing greater clarity to the other areas of healthcare encounter as well. Some innovative entities have tried to analyze what they can, and they're having a little bit of success, right? Notwithstanding what I've said here, I'm a big believer in price transparency. It's going to take a while. And I think we are seeing some data that sort of helps shine a light on what is so wrong in our pricing system. And these academics, researchers, and technologists are developing new price transparency tools that are separate from health plans to try and inform consumers. It's going to take a while, as I say, but I think we're making some progress, and it should begin to shed light on the universe of pricing data over time. Actual rates paid by health plans to hospitals are a fraction of the so-called billed or charge master rates. This is something that the data is showing already. We sort of already understood that, but it's sort of a validation point. Another area that would be good to understand, and studies have also seen this, but the pricing data seems to indicate that Medicare for service inpatient rates are somewhere well less than what commercial rates are. And the data seems to say that commercial rates are on average between 200 and 250% above Medicare. These would be the allowed amounts. So that also is a validation point too. Another point would be, based on both the plan and hospital data, that the academics and researchers are indicating that there is a wide disparity in hospital rates between regions of the country. Again, we sort of intuitively understood this and saw this, at least in the Medicare world, with the Dartmouth Atlas and other analyses of Medicare data. But this data is sort of showing us that there can be vast differences in prices in health plans and in hospitals across the country. So, for example, the northwestern US, Washington, Oregon, are known to be extremely efficient, really, in all lines of business, while other regions, including South Florida as an example, have very, very high spending and rates. So this data is sort of adding to what we knew intuitively from the work in Medicare, in the Medicare arena. What this data is also showing is that hospital rates also tend to differ significantly even within regions. Let me underscore that. So we're seeing vast differences in costs and rates for hospitals and health plans across the country, across regions. But even if you start analyzing the data within regions, which was really not well known before this data, you can see sizable differences among rates paid to hospitals by health plans in regions. And that's a very significant thing. Many people would have told you, well, rates are universally high in a given region, but that may or may not be the case according to the data. And so that's something that, again, is a very important learning here. And we'll learn a lot more over time about differences between regions in all of the lines of business, and even differences in payments within regions. And last, it's also true that each health plan in a given region may pay different rates to hospitals. And that's something we didn't know before as well. This in part may be due to the relationship the plan has with the hospital and affiliated providers, but it likely does not explain all the differences. So more concrete learnings from price transparency filings so far. So let's try and sum up this a little bit here. So what do we really know? So number one, prices can be manyfold higher at a hospital in one region of the country than another. Prices can be measurably higher at one hospital versus another, even in the same region. And finally, one health plan could have a dramatically different price at one hospital than another plan. So let's talk a little bit about the effect of pricing in the system and a little bit about what we've learned from these price transparency filings. Well, number one, I think we can conclude that hospitals and other providers' charge master or billed rates are pretty arbitrary. They're not really rooted in any true cost. These rates are often used simply to negotiate with health plans as to a discount. But these charge master and billed rates tend to harm the system in a number of ways. First, they're extremely inflationary. Providers tend to add to their already outrageous charge masters or billed rates annually to get the best increase in discounted prices along the way. And if health plans aren't always on top of it, those inflationary increases are likely passed through. Available data indicates that hospital pricing is the most inflationary of all service types, save for some certain drugs in the last few years. And that inflationary practice has been here for decades for hospitals. I'd also note that consumers really get hurt in this entire pricing system as well in a number of different ways. We told you a little bit about the fact that rates can vary between hospitals, between regions, and even within regions. Because rates between hospitals vary dramatically by plan as well, one enrollee at a given health plan A could pay considerably more cost sharing than an enrollee at the same hospital in health plan B. It doesn't seem terribly fair. And I would note even members of the same plan have an issue. Let's say member C going to hospital D could pay far more cost sharing than member E going to hospital F. The consumer is sometimes none the wiser until the bill comes in the mail. And the fact is that a consumer or a patient really may not even have a true choice because the doctor, as I noted earlier in my wife's case, may dictate where that service will be provided. It could be the doctor's favorite place to practice. It might even be owned or closely affiliated with a hospital or something like that. So all of these price differences and a bill charge and a discount and the difference in price across the board tend to really hurt not only the system, but health plans, but more importantly, consumers along the way as well. Let's talk a little bit about an uninsured American given all these differences in price. An uninsured American or someone that may be insured but is in an out of network service situation often is charged the charge master or billed rate by a hospital or another provider. He or she does not get the advantage of the discounted negotiated by health plans. And while the No Surprises Act has stopped some outrageous out of network billing, even for those that are insured, some of those situations still exist for the insured as well. And clearly, in all of these situations, he or she cannot possibly afford those charge mastered or billed rates that providers are charging. In the end, as I've said, I support the price transparency rules that have gone into effect. I'm not a neophyte. I know that this is going to take a long time, but if we didn't really put these rules in place now, it would be years and years before we would see a maturation of price transparency in our healthcare system. And that would be even later than what I think is going to be a good decade before we start to see real price transparency in our system. Clearly, these rules are inadequate and they're going to be subject to gaming for years to come. But for the first time, with the help of some savvy technologists and experts, we will begin to have a glimpse into the dirty world of price in our healthcare system. Hospitals and health plans argued that the sky would fall if the rules went into effect. Well, that hasn't happened. Their competitiveness hasn't been crippled, and it hasn't led to higher prices in and of itself, except for those ongoing outrageous prices in general and the inflation that has always occurred. But the rules themselves certainly, I think, are valid. If anything, it did lead to some head scratching at health plans and I guess some hospitals about why prices were so disparate between regions, within regions, and perhaps even among health plans. In my book, The Healthcare Labyrinth, available for purchase at healthcarelabyrinth.com, I argue that a private delivery system will deliver the best quality in America, but I also argue that what America needs are prices that are set uniformly by region and are the same across health plans, at least in various lines of business, commercial, Medicare, and Medicaid, and perhaps across lines of business as well, which would have the effect of reducing the cost shift that occurs from Medicaid and Medicare to the commercial line of this business via pricing. We do this in the Medicare and Medicaid world to some degree in the fee-for-service systems today, and it may be a valid approach across the entire nation, across lines of business, or at least in each individual line of business. This would reduce confusion among hospitals, among plans, among providers, and among consumers. And it would also reduce huge administrative costs along the way. We have so many more administrative costs in our system compared to other developed nations that have uniform price setting because we're administering huge claims systems that all have different prices and things like that, that all have to be adjudicated and looked at each and every time. The fact is, again, that uniform price setting is practiced in all three types of systems in the developed world: socialized healthcare, single payer, and private affordable universal access. In this last version, plans compete not on who can reduce excessive pricing, but on efficiency and quality of care, as well as consumer satisfaction. That's really where we need to get to and take away the absurdity of the price system that we have today. Indeed, in studies of outcomes in developed countries, each healthcare delivery type scores at the top of the pack because the systems are focused on the right goals of healthcare rather than spending money on all of these administrative costs related to price differences that we do in the United States. So the prices are being reported by hospitals and health plans are not clear, accurate, or accessible. We know that. But again, I think we got to celebrate the price transparency rules anyway, no matter how infantile they may seem right now. I think we are going to make progress. In the short and medium term, the data might transform how hospitals and health plans think about price. With data available, they could evolve a rather mature pricing strategy for once and refocus on value and efficiency. Plans and hospitals may also begin to meaningfully engage consumers on price and more. This seems to be an emerging trend. In the long run, clearer data mined by the smart guys out there may better shine a light on the absurdity of our pricing system and lead to even more dramatic change, including perhaps where I want to go on uniform pricing. With that, we've arrived at the end of our price transparency discussion. We hope you enjoyed it, and we'll see you on the next Healthcare Labyrinth podcast. Take care.